Media has been invited into this conference. For the media is to note what is being discussed. Unfortunately, we do not give space to the media to ask questions here in this platform. May I also request that when we start, honorable members, again a reminder, please press on the mute. We had requested you to forward your pressing questions that the minister should address. We would like to make it that way, to say the minister will start with what is briefing us on, together with the questions that you sent in and brought them to his attention. He may not be able to exhaust all our questions that I saw. We are grateful. We will probably be, because some of the issues that the minister would like to get a support on will be from the members, the MECs who are here and HODs. So rather we do that spacing, we give a space to listening to the briefing because the entire leadership of the country in health is here. May I check again if Minister Mkhize has logged in?
Honorable Chair. Honorable Chair, I confirmed with the Chief of Staff the Minister will be joining.
Miss Renee, yes, we know he's going to be joining. Do you have an idea when?
Yes, I'm waiting for that, Honorable Chair.
Okay. I don't know whether the Deputy Minister would like to start, and he's free to do that. We have forwarded you, Department of Health, attended a program where, after welcoming and having introduced ourselves as we have done, we would like the Minister to brief us and give us an update on the progress that we are making as a country on this COVID-19 challenge. There are certain things that have sparked up. One of them, I understand, maybe the reason Professor Abdul Karim is here is an issue of St. Augustine Hospital. The other one was an issue that came up strongly last week about the protective clothing, the availability thereof. We also noted that there's been this new program, a program of testing, firstly screening and testing, maybe getting an update on that, how strongly that is coming in on provinces, the deployment of about 1,000 home care workers countrywide to do the screening, progress thereon. And there is the provinces have been updating, but the reports are not the same. There are provinces that are reporting details of per municipality, so many infected, and the other provinces may have not been doing that. So we wanted to check if there's some uniformity on that part. But then, without being exhaustive, let me then leave to the department to start the briefing to us.
Well, Chairperson, let me just say that it's a rather awkward situation. I hope that the minister is joined, because we haven't had the time to exchange notes on the approach to the meeting. I know that there has been communication with yourself. There was also a consolidation of reports from provinces for the purpose of also briefing the executive and the president. It would be, as you know, the situation is, changes every minute, every hour. There's new developments all the time. I'm just hoping, I don't know whether there's some major difficulty with the ministers joining, because that would actually be the best for him to just set the scene for us to go into the discussion. I was not, as I say, we haven't had a time to talk. He's been in the KZN province. So it's a bit of an awkward moment if he is not here. Maybe Ms. Rainey can just update us. Then we can maybe improvise, which will not be the best if there's some difficulty.
Yeah, sorry, the minister is phoning me on the same line I'm on, so I was not able to take his call. I just cancelled that call, Renee, because I can't take that call and come out of this one.
Honorable Chair, I will step off the line and call the Chief of Staff directly, and then I'll connect again.
Yeah, just call the minister directly. That I'm not taking his call because we are already here. Yeah.
Okay. Okay, Chair.
Yeah. So.
Yeah. Yeah. Look, there is an option that the acting DG, who has been quite involved in the consolidation of provincial reports, could maybe give some highlights of the overall situation. But as I'm saying, it's not the best. It's not the best of arrangements. But if we could consider that, I could ask the acting DG just to give a high-level summary of, looking at various aspects of this whole campaign against the coronavirus. So, do you want to maybe just see whether in a minute or so, if there's clearly difficulty with the minister joining, we could get the acting DG just to give a high-level comment on the consolidated report?
Look, the absence of a minister should not pose a big problem as we start. All of you colleagues are capable leaders to do this process. The invitation of a lot of other experts here is, among other things, to assist us. You could start with the acting DG, but the presence of other leaders here, the MECs too, might add certain areas, because I don't think Dr. Zweli Mkhize owns this program alone. All of you have been very busy on the ground doing a lot of work. I've indicated and highlighted issues that we need to be briefed on. These are members of parliament who are very close to the process, more than other members of parliament. So the briefing that you have been doing daily and the updates that you are doing, as Dr. Deputy Minister is saying, the situation changes every day. We would not hold against the minister for delaying to come in here, but all of you are capable leaders to help us to do that. Maybe the acting DG may start, MECs may add whatever that has been emphasized. Please, let's start.
Yeah, Chair, there's actually, as I said, there's a consolidated report. Let me ask the acting DG to look at various aspects, because we try to also, as the MECs will be aware, we're trying to fine-tune the kind of template of reporting, which I think the acting DG could touch on each aspect briefly, maybe over the next 10 minutes. Anban, are you able to do that?
Yes, DM.
Your call has been placed on hold. Please wait.
I put together for the minister. I can maybe talk very briefly.
Your call has been placed on hold. Please wait.
Yeah, please do that. Just look at the various aspects, in terms of the things which we're trying
Your
to...
Your call has been placed on hold.
If you
please
could
wait.
In every aspect, just touch a bit briefly on that report, yes.
Your call has been placed on hold. Thanks. Please wait.
Thanks, everyone. So I think it's important to maybe at a global level...
Your call has been placed on hold. Please wait.
The spread of this infection is continuing globally.
Your call has
unabated. And this appears to be across all regions, whether we're looking at the European region, the Americas, Western Pacific, Eastern Pacific, South America, etc. So I think it's clearly a pandemic across the world, and the numbers are increasing on a day-by-day basis. Back at home, I think it's important to say that the cases are also increasing. The rate of increase, however, has declined since we started lockdown measures, together with the other measures around the ban on flights and the closing of borders, etc., we saw a significant decrease. We were increasing. We were initially, until the 21st of March, we were having like 30, 40 cases a day, and then from about the 23rd of March, that jumped to about 150, went as high as 225 cases. But since we started implementing the lockdown, that fall has been fairly significant and fairly quickly as well. So by the 29th of March, we started going back to numbers of between 30 and 40 cases a day. We're currently hovering around 90 cases plus minus every day. In terms of the types of the distribution, the cases are predominantly in the age group from 20 to 60. Is the largest disease, and as per the general global picture as well, more males are affected than females. However, in some categories, it seems that there are more females than males. In terms of the provinces that are affected, I think it's well known that the province that's most affected is Gauteng, Western Cape, and then KwaZulu-Natal and the Free State. The other provinces all have cases, albeit at a much lower level. If you were to look at our trajectory in terms of the number of cases compared to the global experience around this, most countries have had an experience where once they started having an increase in cases, it's been exponential, and it's only with very drastic measures such as that which was implemented in China as well as Korea, for example, where the graph started flattening off. Ours appears to be starting to flatten off around the 2,000 mark. You can see the rate of increase is slowing down. We're hoping that will continue, and the lockdown measures are taking effect as we break the mode of transmission between households. In terms of our contact tracing, nationally, the number of contact traces that we have on the ground is 2,600. We've identified 9,547 contacts that have been identified. Of that, we've been able to reach 8,341. We still have to reach 831 contacts. Here we're using the legislation that we have now available to us with the telecommunication companies in order to access the whereabouts and location of these 832 people. We're monitoring these contacts, 8,341 contacts being monitored. The number of contacts that are positive at this stage, 154, and the number of contacts that have completed 14 days of monitoring is 1,347. So many of them are cycling out of
Dr. Anban.
Dr. Domo.
Yeah, is that the minister?
Dr. Mkhize. That's correct, yes.
Okay. When you logged in, Dr. Anban disappeared.
No, I was in when he started presenting, so I don't know what happened. I've been struggling to get through, but I'm back now. And I just want to clear one thing quickly. We have...
Hi, I was cut off.
Yeah. If Dr. Anban is back, we can continue. There's been a bit of amendment which I affected on the slide. And so I'm not sure, have you got these slides already, because they're more in the portfolio committee?
No, Minister, we didn't circulate the slides. I'm just doing a verbal presentation.
Okay. As soon as we got the slides circulated,
put a few amendments on the slide and the order, so we will come in at some point. I think for now you could proceed. I'll just check on that and then I will indicate.
Okay, Minister, thanks.
Okay.
Okay, thank you. In terms of hospitalizations, we haven't seen the kind of hospitalizations that have been projected in many of the other countries as yet. The numbers are still fairly low in terms of the number of hospitalized patients across all provinces, and it appears that the infection is not as widespread as one would anticipate at this stage. If we look at the hospitalization as an indicator of the extent, this is also reflected in the ICU beds, both public and private, the isolation numbers, the high care numbers, those on ventilators, those on oxygen as well. It appears that across the country, they're low across all provinces from what one would potentially anticipate. In terms of community screening and testing, the number of screening teams that we have out there is 1,308. On average, there are about 9 people per team. That does vary across the teams. These team members are deployed across all 9 provinces. In terms of the total number of team members, we have about 31,000 people in total. The total number of people that have been screened is 119,000, and those that have been then referred on for testing, that the PCR test is about 1,501. Of those, the number that was positive is 29, which suggests that the numbers are still very low in terms of the extent to which there are positive cases that we're potentially not getting into the system. If I go to the sorry, just one second. If I talk about the interventions that we need to implement in terms of this COVID modeling, I think it's important to appreciate that the key strategies are to isolate, household quarantine, closing of schools and universities, and social distancing itself, and a combination of all of these are the most effective in flattening the curve. The purpose of flattening the curve is to reduce the demand on the health system at any point in time, and that will have an effect on how the health system will be able to deal with that. The researchers have done some work around when they anticipate that this surge would happen, as we're seeing in many countries where the health system is just overwhelmed with patients. And the initial model suggested that if we did nothing and just allowed the current situation to continue, that around the middle of July, we would then have a situation where there'll be a massive surge in the number of patients. However, we've implemented a 3-week lockdown now, the 21 days, and that has lowered the curve, meaning that the extent to which the number of cases that we now have has reduced significantly. And now we've also introduced an additional extension of 2 weeks. And this 2-week extension will push the curve out even further to around September from the model that we've seen thus far, suggesting that the surge would be around then. The curve is still quite high in terms of the number of cases relative to the capacity of the health system. So we have to do a number of things to reduce that. It's also worth noting that the spread of the infection across the country is not equal. The provinces, as I said, that have the greatest burden, Gauteng, the Western Cape, KwaZulu-Natal, and the Free State, consequently have the greatest surge at the point when the surge would occur. And so these provinces need particular support in order for them to be able to respond effectively to the surge itself. In terms of bed requirements, if we look at the peak on ICU beds, at the lower end, we're looking at about 4,000 beds. At the upper end, we're looking at 14,000 beds. So we would need to plan for that at the lower end, at least for the peak. And then if you're looking at hospital beds, we need about 25,000 at the lower end and 78,000 at the higher end. This doesn't include the beds that we currently have, so we'd obviously have to reduce this by the numbers that we currently have available. We've also done some modeling around what the daily spot estimate is of ICU beds and hospital beds as well, to get a sense about how many beds should we have in place. In terms of facility readiness, both beds and ventilators across each province, we've done some work around trying to estimate what the needs would be, how many ventilators would potentially be required, and how many beds, and get a sense about that. In addition to that, the quarantine and testing stations by province have been identified. The total planned quarantine sites is about 1,644. The numbers that have been currently activated is 21. These sites are currently active. The others are planned, so if we need them, we can then activate them. The total number of beds that are available are 7,356.
Like 10 minutes ago. Yes.
The total number of people in quarantine currently are 609, and of those, about 14 have tested positive. So it's still quite low. We've also looked at the mortuary capacity. I think there's somebody on the call who's speaking. Can you please mute yourself?
Just like play from there, because I am part of the actual meeting. Shelly's there. I don't know. I think I saw you, but then you went out again. Show participants.
On the issue about mortuary, we've assessed the mortuary capacity across provinces and identified the need relative to the capacity. In terms of field hospitals to respond to the additional bed capacity, work has been done on this, and particularly the provinces that have the highest burden, which is Gauteng, the Western Cape, and KZN, as well as the Free State. Sites have been identified, and some work has already started to put up field hospitals. Some of this would be in conjunction with the South African military, and others is where we're converting convention centers and stadia into field hospitals that will be able to deal with those cases that wouldn't require ICU care. In terms of human resources, we've also we have a stream in place that would identify the human resource needs, bring on board all the capacity that would exist, both public and private. The IT system that we have in place is also able to allocate human resources based on needs and burden of disease. We've also asked for retired health professionals to volunteer, and we've had quite an overwhelming response in that regard as well. And as well as the request for support, Cuba is also planning to send health professionals to support us. So I think there are other countries that would respond to that. In terms of provincial capacity, we've mapped out what currently exists in provinces and where we potentially need to augment that at the point of when we're surging. The NHLS has developed mobile testing laboratories that would be able to take samples and then link up with the teams that are going door to door and make sure that the turnaround around these tests are much quicker, so we're able to get a better understanding of the actual community spread of this infection. We've also, in addition to that, introduced rapid test kits, or we're planning to introduce them. These are the rapid kits which measure the IgM and IgG. They're not as accurate as PCR. The advantage of them is that they give you a result in 10 to 20 minutes. It's a finger prick, can be done quite quickly, can be used as a screening mechanism, which would allow us then to take some action in those cases as we expand our PCR. One of the big challenges around PCR is that globally there's a demand for the test kits, as all countries are doing the same testing, and so the security of supply around these kits is fairly limited. Coming to the PPE, we have a detailed breakdown of PPE by province, and at this stage, all of the provinces have sufficient PPE. Obviously, the stocks are very low, and a number of flights have come in with PPE, which we've ordered which are coming by air cargo. Some came in, I think, yesterday, and others are coming in over the weekend and Monday, etc. The intention is to obviously increase the capacity of the PPE, particularly our masks and gloves. And I think by the end of next week, we should be in a much better space as the quantity of PPE that we have ordered comes in. The big problem with the PPE was that we were relying largely on local suppliers. These suppliers, the majority of them have very limited capacity to produce. The rest import. They were unable to import stock in simply because flights had stopped, and so they are highly reliant on air freight to get the stock in. We have also geo-mapped all of the information. Those are the positive cases, as well as the door-to-door screening. So we're able to see heat maps of where the highest concentration of cases are, which would help us then to isolate those cases and those areas in any future measures around lockdown, etc., which would then limit the spread of those infections to other areas. There were a number of heat maps that I had in the slides, which I wouldn't present now because I don't have an opportunity to display them. I think they can be circulated. I'll stop at that point, Minister.
Yes, thanks, Minister. You can proceed, Minister. Thank you for that. Among other things that the Minister will touch on will be what we saw you doing today, also looking into the issue of KZN, in particular St. Augustine Hospital.
Thank you very much. If I may just beg your indulgence, could you just ask Professor Abdul Karim to just come in briefly on the issue of the impacts of the lockdown and the possible trend that we are taking. This is in addition to what Dr. Mkhize has made, and also touch on the issue of specific containment measures that we need to be dealing with moving forward. Dr. Abdul Karim is the chairperson of the Ministerial Advisory Committee, so they've looked at a number of these issues, and part of what we have comes from that team. If they deal with that briefly, I'll then come in on the issue of St. Augustine and the meetings with the private hospitals, the private sector, as well as unions. If it's possible, I would like that we bring him in now for a couple of minutes.
Thank you, Minister. Through you, Dr. Tlomo, I sent through 3 slides to the Minister and to the Chief of Staff. I don't know if you have them, but I'll just speak to the issue. Even if you don't have them, that's fine. So if we look at the current global situation...
Can I just quickly get an email address so that I can send the slides?
I think let's proceed with the presentation.
Ms. Jalamba will help you with that one. So long with
Dr. Aldama, I think let's proceed with the presentation. We'll sort out the slides as we go, but we don't have to wait for them for now.
Agreed.
Yeah, thank you. So I'll take just about 3 to 4 minutes. We look at the global situation. We have now, at a global level, exceeded 1.5 million infections. And if we look at the trajectory at a global level, it is a sharp exponential increase. In other words, if we look at the line, it just shows a rapid rise in the number of new cases almost on a daily basis. If we look at the epidemic curve of all of the individual countries, whether it's the US or Spain or Italy or France or UK, all of these countries have an initial slow start, and then once the virus has been able to take hold and community transmission occurs, we see this rapid exponential increase. With that rapid exponential increase, they tend to get into the tens of thousands of cases within a matter of 2 to 3 weeks. So within a matter of just 20 days or 25 days, most of these countries go from 100 cases to around 50,000 cases. And that just illustrates the rapidity with which infections occur. So the question that the minister asked me to address, so what is our situation? And if we look at the epidemic curve for South Africa, it's quite different in that we initially, in our first, up to the time we got to about 1,000 cases or so, we were following the same exponential increase that we were seeing in other countries. And if you look at our line, that trajectory line, it coincides very much with the line you see in the UK, Italy, and Spain, and even the US. But that only is true up to around the point of around 2 weeks ago. So around the date of the lockdown, the epidemic trajectory has changed, and the number of cases has what we call flatlined. In other words, there's a similar number of cases every day. It's not pushing up the curve in the same kind of way. And the reason that we're seeing this kind of flatlining is that the exponential growth in the number of cases that we saw initially is no longer occurring. So there's some questions as to why, because there's almost no other country that reached this kind of situation where you get to just over 1,000 cases and it then starts tapering off. All of the other countries, it just simply keeps going up and up and up and up. And that's part of the reason, because you have this rapid increase in cases, that you have so many people walking into the hospitals requiring care, and the hospitals just get overwhelmed. But we're not seeing that. And so the question that needs to be asked is, why not? So there's many explanations that could explain it. One of them is we're not testing enough, and that certainly could be a contributor. The other is that maybe we are testing enough, but we're not testing the right people. That's also a possibility. And the third is that, is this a real effect? And there are many ways of looking at the data, but in short, as this flat line occurred, there was a steady increase in the last 2 weeks in the number of tests that were being done in the NHLS. Now, the private sector has always been doing most of the testing, but the NHLS has been steadily increasing its testing over the last 2 weeks, to the point now where they're doing just over 1,000 tests a day on average. So it's probably not entirely due to not enough testing. In terms of being skewed, we see some of that effect, and that comes largely from the private sector. Initially, the private sector was key to identifying cases because they were among travelers, many of whom had medical aid. But now we see that the fall-off is that we are skewing it a bit in the private sector, probably towards worried well. And so we're not seeing as many cases, even though the testing numbers remain pretty high. So it's unlikely to be entirely due to lack of testing. It's unlikely to be due entirely to skewed testing. And it seems that there has to be some contribution to the nature of the interventions that have been undertaken. The extent to which those interventions contribute to this is difficult to quantify at this point, but if I look at a range of other pieces of data, principally around our mortality, then without going into too much of detail, I think we can be reasonably confident that a significant part of this flattening out of the curve is a result of interventions that were put in place quite a while back. And that refers to the first set of interventions that were implemented, closing the schools, reducing gatherings to below 100, stopping the travel, and so on. The effects of the lockdown will now be seen in the next few days. And the reason for that is that when we look at cases Cases tell us about infections about 2 weeks ago. Let me explain that. When somebody gets infected with the coronavirus, it takes about 7 to 10 days for them to develop symptoms. They then have to go to a doctor. The doctor then has to take a swab, or the nurse, and the swab then has to be tested in the laboratory. All of that takes about 2 weeks. So when we say we had 79 cases today, that actually means that those 79 infections occurred on average about 2 weeks ago. So cases tell you about the epidemic from 2 weeks ago. And I think that when we look at this, if the lockdown has had the effect which I think we're going to see, this line that we see, the number of cases, will start steadily going down now. And that should be the net effect of our lockdown, plus the measures we implemented for the lockdown. I'll stop there, Minister.
Thank you very much. Thank you very much, Dr. Jomo. If I may just proceed.
Proceed, Minister.
Thank you very much. The first issue to talk about is the issue of the St. Augustine's Hospital. In this hospital, we have had to issue directive that the hospital be closed. This arises from the first patient we picked up here about 2 or 3 weeks ago was a patient who came from an old age home. We were worried, and then we got the whole old age home tested. They only found the roommate only was positive. But as it turned out, while she was in hospital, after having been there for a couple of times, we then lost one patient on COVID-19. A lady was 46-year-old that suspected asthma, a teacher. And then we were concerned about this Subsequently, we have had about 6 deaths in the hospital. And therefore, when the matter was looked at, we felt it was important to test the nursing staff, the professional team, and the staff in the hospital. And on the tests that were done a few days ago, they've done close to 300 people. They found about 66 people had been positive. 48 of them were nurses, so that they were professionals and staff. And then about 15 were patients. Already included amongst those 15 were the 6 that had died. And then there were others who were transferred to other hospitals. It became very clear to us that we needed to test more of their staff, and therefore the total of about 2,500 to 3,000 members of staff are being tested as we speak. But the long and short of it is that this is a hospital that has shown a huge amount of infection. The preliminary investigation suggested that there was a patient 0 who was suspected, but who never got into the mixing with the rest of the other patients. And there's a suspicion that professionals who were looking after this particular patient could have actually carried the infection amongst themselves and to the other patients. So the real issue now is that that hospital is being closed, and we've only left a small portion thereof, which has got a detached unit, which has about 58 patients. Initially, there were 80, and then the rest of the hospital is being fumigated. They're not taking any new patients. We've communicated this across all the leadership of the hospital and the group that is running the hospital. But what we believe is important is to get a proper investigation to find out how did you end up with such a breach on infection control protocols that you end up with so many staff members being infected. There are even indications to suggest that in the public sector there may be professionals who are working there who are now positive, but were actually linked to moonlighting sessions in this particular hospital. So as a result of that, we're also following a few other hospitals where there are queries that people have raised from the public and from some of the unions. So we're going to be looking at the hospital in Parklands. We're going to look at the hospital in Hibiscus, a hospital in Shifa, and one other, I've forgotten the name, just to check what's happening. And I recommended that we should do sample testing of staff just to be able to sense what the spillover might be. So we will talk about this as we move on. And I think all of us can see that the brunt of the COVID-19 infections are actually in the private sector, less so in the public sector. Now, we had a meeting today with a number of private hospital players. This includes some of the group CEOs of the big hospital groups, as well as the hospital association, which was also represented. And of the issues we discussed was basically the fact that they have to follow strictly the infection control protocols that have been issued by NICD, and to make sure that they must also be ready to be inspected by the government whenever there are queries raised, and that they have to comply with whatever the government is saying at that point. This closure is one of we already did closure in Mpumalanga, which has now been uplifted already because the section was fumigated. It also arose in a situation where a doctor had visited abroad, came back, was found to be positive after interacting with a large number of staff in the hospital. So it looks like we've got almost a situation of that nature in the Centre Customs. So we've therefore explained also to the private sector that there is a role of the district office in managing this and even recommending closure of hospitals, that no one can actually resist that they need to treat themselves as members of the same health team that public sector is already part of, so that there's no problem of cooperation. In addition, we've also said that we recommend that there will be discussions amongst at the provincial level, just to be able to look at the inventory of beds available, but that at a national level, we would want to ensure that the discussions are overarching, looking at the conditions under which we'll take use of private beds, and when there are new conditions to impose, or also when we have to determine the prices. The spirit was cooperative, and everyone will expect to be able to comply and abide by the situation as it unfolds. So we believe, therefore, that we'll continue working well with the private sector. At the same time, our role as a regulator is well understood, and therefore I want to hold that issue at that point and then move on to deal with another issue. We've also got a work stream wherein the minister meets with the private sector who are in the pharmaceutical manufacturing, distribution and supply of medical devices of various sorts. And this team has created their own work streams wherein they look at the availability of certain material, some commodities which are necessary for health, particularly PPEs, pharmaceutical products, and diagnostic kits, etc. In this case, they are looking at the stocks available. Because of the Disaster Management Act, we've actually uplifted the restriction which discourages companies from looking at their resources and comparing prices. So we now hold everybody together into one meeting, and therefore we have got ability to have a dashboard that looks at the availability of the stocks across the whole country. This assists us now so that we are able to mobilize what the government requires by actually moving the stocks from private into public, or from the manufacturers to the public, and also trying to make sure there's distribution so that everybody is able to have access to the stocks. As a result of that, we've also got the Solidarity Fund and the initiatives of philanthropic organizations who have been able to come together and intervene when we needed to augment our stocks. So on Tuesday, for example, we took receipt of some of the PPEs, which are already in the market, but because the government procurement system might be longer, they've stepped in the process. In the course of all of this, we have now got an arrangement through the relationship with China and India to be able to source some of the stock. So all of that means that we've got currently the stock that's being delivered, and what we've got should be able to last us for the next 6 to 8 weeks, depending on the pressure on the patients. But at the same time, there will also be new orders placed so that we can look at sustainability beyond the second to third and fourth month, as it were. So we're working on that. Prices have skyrocketed, the supplies have dwindled, and some of the countries are basically blocking any manufacturer from selling to outsiders because their demands are also very high. But we are managing this, and we've got a lot of support from China. In particular, we've also got support from India as well. Can I leave that part and then move to, well, let me just say that we've also identified certain areas where we need to focus. For example, issue of ventilators. There's a task team that's working on that to try and buy as much as we can get. And then the other one is about certain pharmaceutical products that are going to be necessary for us to be able to maintain good health for South Africans, that is even unrelated to the COVID-19 situation, but just antiretrovirals and some of the chronic diseases, etc. So all of these are part of the cooperative work that we do with the private sector. And then the last one is that we had the meeting with the trade unions. There were 2 meetings we held. The first meeting we had with the MECs, heads of departments, together with the Minister of Labour, Minister of Trade and Industry.
Your call has been placed on hold. Please.
So, hello? Am I still audible?
Yes, Minister.
Yes,
yeah,
Minister.
Audible.
Thank you. Thank you very much. So, in the process, we were then able to discuss with them, and the following day we had another meeting. This involved how PSA, etc. And this was because there was a court case which was in court where how we had taken government to court on the basis of the issue of protection. As we look at our inventory, we believe that at the moment we have adequate stock. What we have to ensure now is equitable distribution across every facility. This allows us now space to say district managers, district offices must look at the stock and make sure that there's adequate stock in the district, but can be moved from one area so that areas of need can be covered. And in the discussion, therefore, with the unions, we agreed that no worker will be forced to do work in a risky area for which they are neither trained nor properly protected. But we then said that everyone needs to make sure that we have understanding of the protocols of use of protective clothing, so that people who might be in less risky areas should not demand what is actually reserved for people who are in isolation ward where the infection is highly concentrated. So all of that we have agreed about. Then we've also agreed to strengthen the occupational and health safety committees so that they are able to deal with the issues of safety of workers and discuss them at local level as well as at the provincial and as well as at national level. We're going to therefore work together and cooperate in this regard to make sure that ultimately we can resolve issues of fear of exposure to the infection. What we ultimately identified is there's a lot of tension and anxiety amongst our staff, and that's why they behave that way. In some cases, they said it was not ill-discipline or lack of cooperation, but rather the fear that made some of the people react in the way that they responded. So we will be addressing that issue. But at the moment, we are satisfied that there is adequate provision. So we're calling on all our managers to be able to look at the distribution so that we are able to cover all the people with the necessary PPEs, as it were. Whilst we are looking at that issue, we must also indicate that the case in court was how we had called on the court to call on minister to meet them and so on. But we had actually had already some engagements with Nehau, and in the process, some of those engagements they indicated that they rather let the court case proceed. But later on, they wanted to withdraw the case in court, and after consideration, the judge decided to hear through the whole matter in court, and then ultimately looked at our response and dismissed the case of Nehau with cause. So on the first day when they wanted to postpone the matter in court, the court then said it will be postponed, but then they must cover the cost of the Ministry of Health, and then the following day the same order was issued that the court dismissed them. But what we think is important is that you need to work very closely, because some of the staff may be worried, but then they not discuss it with their management, but rather with their union. So we need a close working relationship to make sure that staff remains protected throughout the whole fight against the COVID-19. If I may just reiterate the point that's been made by the acting DG, as well as the Professor Abdul Karim, we believe that there's been an impact on this rate of spread of the infection because of we have basically literally cut off the peak that would have been associated with the imported cases. It's not going to happen anymore until we open the borders again. So that's a huge achievement from where we sit. The second aspect is that the internal spread would have also started rising pretty rapidly, but we frustrated that by ensuring that we stop all the major movements in trains, in taxis, through the lockdown and buses, but also by stopping large gatherings of meetings, churches, Good Friday, music festival, football matches, and all of that. These together made sure that super spreaders don't come into one space and spread infection onto many people. We do have a situation in Bloemfontein where 5 people were part of a church experience, and suddenly they are the major driver of the infection in that area. At the moment, the numbers in the Free State are largely due to people who came from the one church experience. We've now seen that that spread has gone to Northern Cape, to Ekurhuleni, Gauteng, and Northwest, and therefore we know that you can actually have that incidence becoming the major driver of the infections. Chairperson, I think we could take some of the questions. We tried to go through the entire list that you provided. I think we've really responded to almost all the issues that you have raised. The one point which we didn't go into too much details about is relates to the tests. Right now we're doing PCR tests, and the capacity that we have allows us to be able to do a minimum of 5,000 per month. With the mobile tests having been rolled out and more capacity on the equipment, we will be able to get to a point of being able to do 30,000 tests per day. Currently on stock, between what has been supplied a couple of days ago, we should have capacity for almost 600,000 tests, which covers us for the next couple of weeks. So we think that in terms of our contact tracing, in terms of our screening of communities and proactive testing, those will help us to be able to discover more new cases. We're also advising our provinces to start creating fever or flu clinics on the site, which will divert people who might be having respiratory symptoms to be treated in an area where they're treated as suspicious of COVID, so that isolation will be possible. And we will do that as we go into the winter, so that they can then divert them to some of the field beds and make sure that we sequestrate those who might be positive from the general hospital, so that there's no new infection. This is the experience of Wuhan that we have seen. So we believe, therefore, that a lot of work will be done. The question of masks has also come on board. The Ministerial Advisory Committee has said to encourage everyone to use masks, and therefore they can also use cloth masks, so that those can be used by community, and that the surgical masks and the N95, the FFP2 or FFP1 and all of those categories, surgical masks and so on, should be left for specialist care where high intensity treatment is happening, and that way we'll be able to conserve the meager resources and then allow people to use protective clothing, protective masks, because the research that has been done has proven that the exhaled air of people with COVID-19 infection basically contains very minimal or no viral presence if someone is wearing a mask. So there is evidence that the mask will actually protect anyone from those who have got infections if they are wearing the mask. These would be the things that we have to encourage now when we get to lifting the lockdown, hand sanitation, the masks for communities, distances, and then we continue with the testing on the side, mass screening, picking up symptoms, rounding up contacts, and targeting red zones or vulnerable areas where in a township or in an informal settlement we spot someone who's positive or we spot someone who's a contact. Those we'll need to continue with. At the end of the day, the only protection we'll all have is either if you've been infected and you develop immunity, or we get the vaccine administered. Now that the process of that hasn't started, except in UK, US, China, and Australia. And when the time comes, we might then be also involved in this, and we believe that participation in that vaccine is important, in the vaccine trial is important. At the moment, we will participate on some of the current therapeutic trials because we need something to intervene when people are critically ill using the world experience. So at this point, we haven't got too many people in our hospitals, and we believe that we could then be charting a different path, different to the countries that have actually been inundated with huge numbers of patients right now, and probably if we are able to all work together, begin to show a slow transmission curve that will allow us to be able to manage this. We're worried about winter, where there's going to be an explosion. We're worried about the lifting of the lockdown, where there might be also another rebound explosion. So these are the things we're looking out to. At this point, I would like to just hold it there, and thank you very much to the Portfolio Committee. MECs are here, and the HODs, so they can answer questions directly. Ministerial Advisory Committee members are here. NCD is here. NHLS is here. So we will all be able to answer the questions. Thank you very much, Chairperson.
Yeah. No, thank you very much, Minister. We agreed with the members that it may just be very difficult for us to round the whole conference with questions. We send those that you have talked to, which were very critical for us. We hope that maybe in a fortnight's time we might have another meeting of this nature. And as Deputy Minister was saying, things change every day and every moment. But I think we would have believed you. But by bringing in an epidemiologist in the caliber of Professor Abdul Karim Slim and explaining that curve has assisted us a great deal. We really commend. We are actually thanking the MECs. When we want to encourage MECs to continue also in the way that we have done, to provide explanations and support this program in our various provinces, because the issue is about dealing with the anxiety and the panic amongst our people. And if we are there on the ground, it helps us a great deal, as you explained continuously. We want to encourage you to do that. We would probably not be able to open up more for questions. It was also under the instruction of the House Chair, who actually said that, Dr. Dlomo, we are pushing this meeting on a holiday. Please limit it to an hour. And I have to respect just that. And we might have to, in a fortnight's time, Minister, after also receiving these slides, I'm already on page 7, writing my own notes from your presentations. So we might have to do it in another fortnight's time. And I'm sorry, honorable members, if we are not able to do any questioning now, but we agree that it may just be a bit challenging to start this process now. We were right. We're happy with the input and the presentations. And I want to hear if there is any objection to hold it at that for now.
Chairperson.
Okay. Yes, Philip.
Chairperson, may I ask that when I know the minister is very busy and is doing a good job in what he's doing, but may I ask then that the next meeting you suggested be happening as soon as possible, then maybe next week, early next week, if it's possible.
Yeah, I'm not sure, Philip, whether we can't delay it to later in the week. If we have it early next week, Easter Monday, we will not be getting much Tuesday. Why don't we agree to say we'll work on that, but towards the end of the week, if we need to, not very early in the week.
That's fine with me, Chair. I'm happy.
Chairperson Lindy Wilson.
Chairperson.
Okay, let me listen to Wilson first. Yeah.
Thank you, Chairperson. If I may just say, while we're on the line with the Minister, and to the GG and all the staff who've been working tirelessly as a result of this pandemic, I think we really owe the Minister a huge thanks.
Sure.
I know that he and his team have been working unbelievably hard and fierce hours, and I am sure they are absolutely exhausted. Minister, I want to thank you, and I'm sure that the rest of the committee will agree with me, that you are constantly in our thoughts and our prayers, that we pray that you are given strength on a daily basis to continue doing what you are doing under fairly hectic circumstances. And I want to thank you sincerely for everything you have done today. Just 2 questions, Minister, and they don't have to be responded to today. The first one is obviously the bad news at Polokwane Hospital, where we're now seeing a spread amongst the doctors there, and I believe the hospital may be vacated. And lastly, Minister, from my side, if we can just please, if there is somebody within the department, you can please send us a list and contact details for all the current quarantine sites. It would be greatly appreciated. Thank you, Minister.
Thanks, Chair. I just before perhaps we close the meeting, I've just got 2 questions. The one is a request and the other one is a question. The one request is whether it is possible, and this is directed to the Minister and the acting DG, whether it is possible to perhaps have a consistent reporting of the stats. So, for instance, if we decide that every single day at 12 o'clock we will receive stats, whether or not they are a complete reflection of the cases for the previous day, I think it helps with the consistency. It helps with quelling panic, so that instead of having, sometimes we have the stats coming in the morning, sometimes in the evening, sometimes late at night. And so is it possible to have a specified time for the stats to come in from the Minister on a daily basis? And then the other question is this related to the effects of the lockdown, which we are meant to be seeing quite soon as per the Minister or the acting DG. But what I just wanted to perhaps find out in the Minister's closing is what kind of capacity building or what kind of interventions are going to be pushed for from the health side for the next 3 weeks of lockdown? Because obviously the lockdown is not a sustainable strategy to contain the pandemic. So what are we going to be doing in the next 3 weeks to make sure that when there is a lifting, whether it's a soft lift or whether it's an abrupt lifting, that we can actually mitigate the spread of the virus going forward?
May I request, Honorable Kwahuba, that detailed response be forwarded to the Secretary, and we can get it on WhatsApp tonight or early in the morning.
Chair, Janji.
Yes, Janji.
Good evening, everyone. Thank you, Chairperson, for the opportunity. I just want to echo the sentiment echoed by my colleagues of thanking the Minister and the team, the OH and the provinces for the wonderful work they've done. Just a concern, maybe the Minister would respond later to this. The concern about the moonlighters at St. Augustine, the ones that would have been working in our facilities, whether it is the process of getting them so that they should there be some who are already carrying the virus, they should not spread it to our facilities. Thank you, Chairperson.
Thank you.
Shirwa.
We'll also get the response. Yes, we'll get a response on that, Minister, reaching down to us whether you are tracing those who are moonlighting and what are we doing about it. Thank you. Shirwa.
Thank you, Chairperson. Minister, shout out to you and your team for the work you've been doing. I just have clarity seeking questions, but the other ones I'll send them. There'll be written questions to the Minister. I want to know in particular about information and communication systems, because I feel like that's where we have a huge backlog, which is actually affecting the reporting and communication, information dissemination that should be happening on time. I want to know what the strategy is of the department in strengthening the information and operational systems in for the whole period of the lockdown, and also the quarantine sites that are being utilized by the department. If we can have a list of that, that'd be great. And lastly, with the private sector, I want to know the jurisdiction of the department in regulating the private sector beyond just the meeting that we had with them and the concerns raised by the health workers with PPE and all of that. Because I've been getting a lot of complaints, in particular from cleaners, both in the public and the private sector, that they don't get protective, the PPE whole thing. And what then happens in cases like that, where it's not necessarily health workers, but cleaners who are affected and who are not covered by the trade unions that you were speaking to and all of that. And also, last time, I think it was very early on, this is the last one, very early on, and the minister was speaking about the public sector or the department strengthening the private sector in terms of doing lab tests in regards to the coronavirus thing. And now we know that, well, about a week ago, of the 40K tests that were done, 6,000 were done in the public sector. How far are we in strengthening our laboratory services in terms of conducting more tests? Because I feel like we are putting the burden of deciphering what is happening in the country in the private sector, which not many people have access to. So I want to know what is the number that has been tested in the public sector so far, and how we plan on strengthening testing within the public sector beyond screening. Thank you so much, Chairperson.
Any other member of the committee?
Chairperson, Hasina Ismail.
Yes.
May I go
Okay,
ahead?
let me just check. Hold on. It will be Ismail and Jacobs. Any other member would like to say something? Just those. Mam Shengwa, anyone?
Yes.
3. Okay, in that order. Ismail.
Thank you,
What about Sokacha?
What about me?
Sokacha?
I don't know about Sokacha. I don't know about Sokacha. Have you indicated you want to say something?
Yes, I did. All of them. I'm trying to not press my mute, but I've been pressing all the time. Sokacha.
Okay.
Can you please
I haven't
also
heard you.
register me?
Okay, let's get. Hold on, Ismail. Not too long.
Thank you,
followed by.
No problem.
Hold on. In that order, followed by Jacobs, and the third one will be Hendrik. The third one will be Hendrickson. The fourth one will be Sheikh Imam. Sheikh Imam is number 4. Number 5 is Sokacha, and the last one is Gela.
I've been raising my voice.
What about
I missed you, Mam Shtenga. You coming in before Sokacha?
No,
yes, sorry.
I've been shouting earlier.
Who's that one now?
Chair? It's Mr. Munyai.
Who's that one?
Munyai.
Oh, I didn't hear you. Then you the last one. Okay.
He's the last one.
Start,
Ismail. Thank you.
Yes, do start.
Minister, thank you for your presentation. We really appreciate it and your good work. Firstly, I just want you to comment on the manner that the department is getting in all the steps of the screening and testing thus far done. It's a bit worrisome when we cannot get steps reaching down to the relevant regions. I'm just wondering, usually we usually have a universal app that our hospitals and clinics use for updates on TB and HIV and everything else. Can we not rather use a universal app where each hospital, clinic, lab can update so that we can have it at once given onto a grid so we can pick up immediately, exactly the amount of steps? That's one. 2 is we welcome the mobile testing labs. I just want to know more or less where are these situated. And thirdly, the PPEs, we know that you are importing and we also encouraging, manufacturing from within South Africa. I'm just worried since the lockdown, our manufacturers allowed to get the necessary SABS approved material to be able to make or manufacture more PPEs. Because I've had some queries from those that are interested or already in the market for making PPEs, and they're challenging that they can't get materials because of the lockdown shutdown. Thank you. That's all from me.
I hope that members are aware that the minister is not going to answer all these questions now. We just want to check them. Yeah, okay.
Chair, thank you very much, Jacobs here. Let's start by thanking the President and Cabinet and his entire team, and then the Minister and his team, and the acting DG and his team, and we've all been observing this and realized what a great job they've been doing in the past few weeks. I have a question with regards to the presentation of Professor Karim. He's saying that we see infections 2 weeks later, or when we test the tests which we refined as positive would have been infected 2 weeks earlier. We're now 2 weeks into the lockdown, so we should be seeing a further flattening of the curve, us being now 2 weeks in the lockdown. And if we do not see that kind of flattening, I would like to ask the Minister whether we are prepared with additional hospitals or temporary buildings, or what other measures are there in place should we see the curve actually rise and not flattening as we are actually hoping for it to happen. And my second thought is on the food parcels. Now, I've been working in my province on assisting our vulnerable people with food parcels, and we're having a serious challenge with SASSA and with the Department of Social Development. And I asked the Minister to assist there. We see water having been taken to certain areas, but there is a real challenge with unlocking food supply to the poor people. Thank you.
Yeah. Sorry, honorable members, please. The only person who's going to have the phone on is the one talking. The rest of us, let's put them on mute, please. The next one.
Sokacha, Chair.
Kacha is down the line.
Thank you, Ma'am. Can I come?
It's Hendricks now. Hendricks now. Honorable Hendricks. Okay, let's keep him. Let's go to Mam Shengwa.
Sheikh Imam.
Can Sokacha come in?
Sheikh Imam, come through.
Yeah, thank you, Chair and Minister. Allow me to comment your department, yourself, and the role that you are playing and the way you're handling this crisis and this pandemic we got in the country. My one concern is, and I know that you spoke about St. Augustine and a few hospitals, particularly with the moonlighting. My concern is the patients that were transferred from there to different hospitals and what mechanism or process you've put in place to test them at the different hospitals to ensure that there's not an increase of those infections or no transmission from this hospital to that. And secondly, also RK Khan Hospital had a positive case who's now been transferred to Gray's Hospital, but the patient has been there for a few days. And if you can just at some stage give us a report on that, whether there's been any further infection as a result of that. Then the other challenge is home-based carers. There is no provision for these people to go out there and treat and care for these people because there's no permanent thing. So I'd like you, Minister, to look at that when you're making some amendments to your regulation. And finally, with the shortage of masks in the country, should we not allow the small-scale manufacturers in the informal sector with small businesses and CMC factories, if we can just relax some of those regulations so more masks can be produced at a cheaper price so that it will be available to the public to try and prevent any further transmission? I'll stop there. Thank you very much.
Honorable Sokacha.
Thank you very much, Chairperson. Chair, let me first thank yourself and thank the Minister for this program. Both of you, I like your approach as people who believe in science. The team of the Minister, and you have made us also as the members of the Portfolio Committee to believe in science. My question, Chair, is around the recoveries. I've been looking, you have made us also as people who must believe in science. As I've been looking at the number of people who have been affected in South Africa, the number increases. And I've been looking at the number of recoveries. That's where my concern is. The people who recover. I'm interested in that number. And also, I'm also interested in that number that recovers. How many of them are rejoining the circle? Because there's now information that says people who have been affected, the disease can resurface and later things. I'm very much interested in that. But I really want to thank you, Chair, and the Minister. We are very privileged in South Africa. We have people like you who believe in science. Thank you very much.
Thanks, Honorable Sokacha, for your comments. Honorable Gela.
Not Slangwa. Thank you, Chair.
Your 10K, Mam Slangwa, you were not there. We'll come back to you again.
Thank you very much, Chair. Let me also join the other colleagues by taking this opportunity to thank the Minister and also MEC and yourself, Chair, for availing yourself for today. Really, we are happy about the report, and my questions were answered by the Minister and also by the acting DG regarding the issue of PPE. But my other question, Chair, is the issue of food parcels that were raised by Honorable Jacobs and the issue of temporary shelter for homeless. Currently, I know that there is a work that is being done, food is being distributed in other areas, which we really appreciate the measures that the government is doing for our community. But also, Chair, in other areas, there are rural areas that need also to have a water tank because in their areas, there are no water. So if it can be looked at to that thing so that at least they also get water so that they can be safe. The last one, Chair, I just want to really take this opportunity to thank the minister and his team for a good work. Today, I just saw on the news that there will be also a cloth mask that will be provided, when he was encouraging that people must also do those masks for themselves, which is a good thing. We really appreciate the work and also the concern from PSA regarding the unsafety of workers in KZN, which I'm happy that they met with the unions and addressed and agreed on moving forward, that they are going to work together to make sure that we defeat this pandemic. Thank you very much, Chair.
Ma'am Shengwa, we are back to you. We skipped you because I called and I didn't hear the response.
Thank you. I'm sorry, Chair. Let me welcome the presentation that was done by the minister. That is, the minister was working almost daily. Thank you, Minister, for your work you have done for the country. Mine is true. May I have a clarity? That was a clarity on this deployment of 1,000 people to the clarity of the moonlight staff. I thank you.
Have I left out any member who would like to do that now? Oh, yes, you are the last one, Munyai. Hold on, Munyai. Is Honorable Hendricks back? Not there. So can I confirm that Honorable Munyai is the last one?
Yes.
Okay, Munyai, go for it. Sure.
You know, now I'm very disciplined. I'm not going to ask questions as you suggested. But fundamentally, it's important that since the global outbreak of the novel coronavirus, which really brought the unintended consequences to humankind, and we've seen our country, Team South Africa, being very active. And I know, Minister, I'll do injustice if I don't thank even my MEC, Dr. Bandle Masuku, which is the epicenter of Gauteng, who I've seen side by side with yourself doing his work. But the point to take forward, Honorable Minister, Dr. Zweli Mkhize, is the following. One, I think in part of the regulation, it needs to be declared that those that are carrying, that knows deliberately that they are infected, and carrying this to churches like Free State and other areas, they should be declared a murder carrier. They should be not different from a person that are committing murder. And I think if that's done, because that will be very much important in my view, because it can be accepted that even those international guests that came to Free State, whom they knew that possibly they could have been infected, then they must be found in who they are, because they've been the consequence of the spread at some degree. And I think I agree with the report that indicates the global perspective by Dr. Karim. As we have noticed that 1.6 million infection has been more than, in fact, 1.5 million today are infected, and 90,000 deaths. So I think really, having seen the measures and containment South Africa tried to take forward, I think really we should appreciate even the extra days to be able to see what could be the possible outcome given the intervention that the ministry and the team collective is undertaking. Thank you very much, Chairperson.
Yeah, thank you very much to all honorable members. Back to you, Minister, and your team. Maybe you could just prioritize those questions that you think, like the issue of Honorable Chirwa and the one of Professor Karim Abdul Slim, and whichever other ones, probably another 15 minutes, so then we then round up. Thanks.
Thank you very much, Chairperson. Because of the time constraints, I will charge the questions. I won't open up for my colleagues to come in. But let me say that we have all the MECs You have all the HODs, you have representatives from the NICD, the Laboratory Services, NHLS, the Ministerial Advisory Committee, and of course, advisors, Deputy Minister. All of us are here. When you send us messages of support and appreciation, of course, I'm the spokesperson for a huge team of professionals, starting with the leaders who are here to the professionals on the ground, as well as my colleagues in cabinet, because all of what we project is always work that comes from all of these teams. That we have been able to cooperate, that we have been able to work together, shows the level of commitment of all South Africans. And I want to say we are very encouraged by you as members of parliament. Earlier on, we had political party leaders. They were able to show exactly that the way to go is to actually remove all politics in this matter, work together, and all of us must do our very best to save our nation. And therefore, all the work that's been done is collectively done by all the people who are part of this whole team. And I want to say thank you to you for the comments, but I'm glad you are saying it because to the team here, they know they are the ones who do the work. And everybody knows there are days when we don't sleep, and if there's work to be done, you don't talk about sleeping hours, you don't talk about working hours. Everybody knows we work and call and talk throughout the day and night. So this team is your team that's done all the work. So I want to say thank you very much. I will then run quickly through some of the issues so that you can clear those that can actually be clear.
Yeah, sorry, Gangane Minister. If you can put all our phones on mute so that even that colleague who's sneezing very strongly can sneeze without coming into this conference. There's a very strong sneeze.
Nobody's sneezing while they're on the conference call because their phone's not up.
Yeah, continue, Minister. Thank you.
Okay. They're not all muted. Still, I think sometimes it's difficult to know where to mute. So, but I'll continue. Honorable members, Honorable Kwahube, we have tried to put all the results at the same time. There's a lot of data cleaning that tends to delay the situation. There's a lot of reconciliation, corrections that have to be done. Particularly as we're increasing the numbers, we find that some information is incomplete. That makes it difficult to release these stats at the same time.
Honorable members, please, if there's a pressure to speak, go outside and leave your phone.
I suggest that the minister can respond because members are not disciplined with muting.
I can tell whose voice I can hear at the background. Please, colleagues, please mute. Otherwise, your voice is your identity. Will call your name just now. So, yes, you. We can tell it's you. Now, so the issue then is we're working on concretizing the data integration system that will allow a lot of the information to be available online. Then we'll be live and we'll be able to release information as it comes. Right now, we have to do a cutoff of 12 o'clock and then clean up the information. So that's where the inconsistency comes from. The other issue was strategy on the lockdown. Effectively, we've raised the issues all. Firstly, the issue of containment relates to masks by everyone, and that's why we're promoting the cloth masks, which people can manufacture for themselves. They don't need to buy them, and they also need to, there can be small businesses involved. So it's a community effort now. Everyone must go out there and do something to prevent the spread. So that's where we'll deal with that. The issue of hand sanitation, the issue of distances between people, those issues are now going to be part of our culture. That's one sort. The second group of issues is to create a barrier particularly when the winter days come, where we can triage people and keep on the side. People are coming with respiratory tract infections and symptoms so that they don't contaminate the rest of the hospital. So all of that is going to be something that's part of our strategy going forward. The other issue relates to creating more beds, filled beds. Every province has got plans of how they're going to create additional beds, filled beds. In fact, we are estimating that there will probably be close to 4,000 filled beds that will be created across the country. Some of the big centers have already identified these, and the processes of putting this up have been started. So there is a very clear strategy at that level. We'll obviously have to monitor how we can deal with large traffic areas beyond masks. What is it that we can do to screen them? I think that's the part that we have to separate with time so that we can reduce symptoms on the overcrowded trains and so on. So those issues, let me just leave them at that. The quarantine sites is going to be a bit tricky to give a list of the quarantine sites so much because the quarantine sites don't operate independently of the district or the provincial government. Provincial government identifies the site, manages it, and then gets the people who need to go there, then they identify. So they will not run on their own. But if the members would like to visit those sites, I would suggest that then we can get our team, the MECs, to give us a sense so that this may be available. Just that for us, what's important is that those sites must be managed on the basis that there are people who will come in, after 14 days they must leave, and so on. So they would be run, maybe it might be hotels, it might be schools, it might be other things. So we will need to get clarity as to exactly what we want to do at that level. Regulation of the private sector, we actually have got authority to regulate. Licenses are done by government, and at some point we have indicated that we are going to handle this at a national level and invoke the delegation to the provinces until this process is over so that we can ensure consistency. But when it comes to inspections and monitoring of the infection controls and management of the COVID-19, we have a right to step in anytime. No one can question that. And then we have got an obligation to make sure we oversee. So there's no difficulty at that level. The PPEs, I've spoken about this. We can share with members details of what amounts of PPEs are available in every hospital. It's difficult to discuss the issue from the point of view of anxiety because people complain about PPE. In fact, some of them are complaining on a matter where they don't really need that much PPE. They have got it, but they think that they also are qualified for the same PPE that is used in the highly infected isolation ward. So it's a matter of information that we're going to work on here. If there are any further questions, we'll deal with it. I didn't understand the question about Polokwane. I hope it can be clarified so I can follow it up properly. The staff that is moonlighting, we will be testing the staff and we will actually track to see which way they move. And where we see that they actually are causing cross-contamination across hospitals, we're going to actually put them aside. In any case, those staff members that are already infected are out in quarantine. They are working neither in the public or the private. They will be out of work for the next 14 days. The patients who have moved, who have been transferred, are all going to be tested because, as I said in my report, from the 1st of March, all those patients must be checked so that we can see if they are positive or not. We are working on that so they will not escape our attention. We've made a call. I've spoken to the CEO of Netcare to say I want to see that they actually call these people. They've assured me they've issued out all the notices to call these people back. So we're going to monitor that with the problem. Communication system, I've explained the issue of the data that's causing the delay. It's not more the inability to keep the time, it's more the time it takes to clear the problems. There have been a few times when we had to issue results, having had to do quite a lot of reconciliation. Sometimes you find that what we issue out, the MECs now know that is not necessarily the same because of this lack of time as well as the fact that we have to reconcile. So this is something that will be corrected once our system is up and running, and we are not far from that. The the private laboratories are actually testing on demand because people can have to pay for that. But insofar as the public health sector is concerned, we've actually increased our capacity to every province, and we've also put up additional mobile vans to augment that capacity, and we are looking at additional other equipment to be able to do that. So we are quite comfortable that the public sector is actually capable of matching the demand for the tests that we are going to be doing. I think it's important to say that South Africa has to keep a close watch into the researches that are going on in the world. As we speak, we will be participating in the trials that relate to what they call the solidarity trial, where we are looking at various therapeutic agents that could be recommended for dealing with the COVID-19. We've got a team of led by Professor Helen Rees, a team of about 30 scientists in South Africa and 10 universities and research institutions that are going to be participating in that. We do need to participate in the vaccine trials. They are not here yet. They will come in the next few months. But at the moment, the phase 1 is being done by UK, US, Australia, and China. But the narrative in the media needs to be corrected. No way can we manage to get immunity against COVID-19 unless we either get infected by the virus and survive it, or we get a vaccine. So we need to actually be very close to the vaccine process. South Africa has got technical capacity to do that. So we need to encourage everyone that we do support the vaccine trials, because all the world are going to be participating. But those who will not participate won't even be in the first line to receive the vaccine when that vaccine is now available. So that creates us a problem of vulnerability. The testing sites, we will ask the provinces to be able to just indicate where the test is taking place. It's obviously going to move from area to area, but then we will ask them to deal with it like that. Manufacturers of the PPEs who can't get supplies, well, they need to work together with the rest of the private sector, because we are able to collectively approach China and other countries, South Korea, for the kinds of supplies that we need, but they need to be part of the public sector team, private sector team. Stavros Nikolai is one person that can be contacted, and they can work with them like that. What Professor Slim was talking about was that you get today, whatever you see of the people are turning positive today, that means they were not infected today. That means they were infected possibly about 2 weeks ago, because you get infected and there's an incubation period, and then you develop symptoms, and then you get to the doctor and get tested. That period means that by the time we find out you are infected, it's a number of days long after you've been infected. That's what Professor Abdul Karim is talking about, and is therefore saying what we see on the ground goes back to some of the restrictions that were put in place. But for the lockdown, there may be still more results that you might be able to see. Maybe they will be visible, maybe they will be diluted by the proactive testing that we will be doing, but nevertheless, the issue is there is already an impact, and we believe that lockdown will show at some point or another that there was an impact on flattening the curve. But what if we do not flatten the curve? We already are ready. Part of our containment strategy going forward, we are going to be putting up additional beds. We're going to be diverting people to the hospital so that there can be flu or fever clinics on the side where people can be tested. So we're going to need to hold that for a while until we can see that the wave of infection is reducing. So we are ready in the event that we get another peak. We want to fight that peak. It was the first peak we've dealt with. The second peak we're delaying. The third peak will come with the infections during winter. We want to defeat that. Then after that, there's going to be an endemic COVID virus that we're going to have to deal with. We must defeat that one as well, so that we are able to say, well, at any one time, the infection levels are less than what we need to overwhelm our hospitals. So we are ready for that. The issue of food parcels, we will raise that with SASA. The RK-CAN patient, we will refer that to the MEC to look at the condition of the patient. The home-based care, all the people on the ground that we need to work with, we will actually activate. At the moment, we've got 57,000 community health workers on the ground, and we will then look at what other categories need to be looked at. My colleagues will take into account those comments. Masks for small businesses, that there's space now for that. Then people can do the mask as long as they can try and do a 3-ply mask, and then make sure that they keep it clean and they wash them and so on. Then that will encourage recoveries. Honorable Sokacha, right now we've announced 410 people have recovered. It takes a while because you need to have about 14 days before you can actually declare someone as having been recovered. So that's why we were slow. Everywhere, excuse me, everywhere the recoveries tend to trail behind, then they slowly catch up. Right now, we've got 410 of them. Then there is no risk of reinfection, fortunately. This virus has not shown that it is mutating since December to date. So all those who are infected have now got immunity. And after a few people are infected, we'll all wish we had been infected and recovered, because that's the only way you can have immunity, that it won't come back to you again. So there is no risk on those people. Then the issues of concern about safety by unions, we have actually said that we will work with them now, we'll work with management to make sure we pick up those issues. No member of our staff must be left unprotected. Everyone must have the kind of protection of the same level that they require because of their exposure, and that we will make sure we provide as much support for our staff to be given the PPE that they require. There shouldn't be any problem at that level. The point about deployment of caregivers, I think that when we release the stats, they will be able to see how we've deployed them. But we've got enough people to do tracing. We've got enough people to go out and do screening. And so those numbers will show when we give you the report. Then deliberate infections, it is actually true. We've targeted several people with attempted murder. When they are told to go and quarantine yourself and they break the quarantine, we charge them. The first case was charged in KwaZulu-Natal in Lady Smith. Another one was done by the MEC of Northwest, where somebody absconded and went into Gauteng. The other one was done by the MEC of Limpopo, where the person moved from Alex and went all the way to Polokwane, Limpopo. So when that happens, we actually deal with them. The other point that we also deal with are that there are people who want to profit because of the crisis. Those people, we report them so that they even stand the risk of their trading license being revoked. So already DTI is working on that. Competition Commission is working on that. So we are wanting to force everyone to stick to pre-crisis prices, except for the currency exchange rate that has changed. We really want to fight those things. At this moment, though, we are seeing a lot of high prices, and we are trying to fight that situation. All in all, I want to get back to saying thank you, members of the Portfolio Committee, on behalf of all my colleagues who are here online and the entire workforce at health and all the public and private role players in the health sector. We are working together well as a team, and therefore whenever you hear us saying something out there, you must know it has been processed, it has been implemented by all the people who are here. I want to thank my colleagues, the MECs, the HODs, Deputy Minister, the Ministerial Advisory Committee, NICD, the top management at NDOH and NHLS. All of you colleagues, I want to say thank you. But for you, members of the Portfolio Committee, thank you for giving us a chance to discuss this matter. We will be ready next week to discuss with you. But we want to say your support all the time. We get your messages, we get your calls, and sometimes we don't answer them. But thank you very much. I really want to thank you. I know it's been long, but thank you, Dr. Domo and the entire team that has organized this. We are really very grateful. Thank you.
Minister, on that also we want to say unanimously you have heard for yourself members of this National Assembly Committee on Health, thanking you and the team that you lead, all those colleagues that you have mentioned from the Deputy Minister, MECs, HODs, NICD, the Ministerial Advisory Committee, SAPRA, NHLF. We thank you very much for the work that you have done, but we would still ask you to continue with the work that is telling, because we are actually in the right direction. The words of Professor Abdul Karim Slim make us to relax and they say we are in a different curve than the rest of the world. But thank you very much. Yes, we will communicate with you as to when we may meet again next week in this session. Honorable members, thank you very much for participation. Thank you, MECs, thank you, HODs, and all our staff in Parliament for setting up this platform. Thank you very much. Good evening to all of you.